Good morning, everybody. Good morning, and thank you all for showing up bright and early on this frosty day. I think that it's warm in here, and the pieces that you're going to hear today will also bring out the warmth in who we are and what we do and why we do it. This is our second Humanities and Medicine Grand Rounds. And this one, and moving forward, is dedicated to Gary Wall, who was the fourth person to speak last year. Dr. Wall, for anybody who might not know him, was, a constant feature at this hospital and in the last several years in Newark Wayne as well, and meant a great deal to many of us and represented the sine qua non of what it means to be a clinician and provider. I remember when I got here in '95, the thing I found immediately alarming about him is when I asked him a question in the ICU, he just looked at me and said, "I don't know, Paul." And I just was completely unaccustomed to that, and found out with the following 24 years that this was very much his style. At this podium, he was erudite, but when you spoke with Gary, it was always as if you were sitting down and having a conversation one-to-one, and somehow he managed to bring that even to the podium for Grand Rounds. Many of you were treated to his discussion on collegiality, which was one of the central themes from his talk last year. And it's great to see a Grand Rounds that is as full as it is today and actually still filling up. I want to thank the Wall family who are here today, Nadine Wall, Gary's mom, Kay Wall, and then the two daughters, one who is unfortunately going to be live streaming today because she's a Brigham and Women's, and that's Allison, and then Lindsay is here as well. So thank you all very much for coming. Oh, do I have that backwards? Okay, good, right. That's backwards, everybody. All right. Our speakers today are the following seven. Unfortunately, I have to quickly add that poor Kathy McGrail had her own emergency. She will not be speaking. She asked me if I would read her talk, and I said, Kathy, just wait till next year. And so I'm hopeful that she'll be at this podium next year. So that leaves us with the following six people. We're going to start with Dr. Gandhi from bariatrics and general surgery, and a refreshing perspective, and how nice it is that a surgeon is joining us at internal medicine Grand Rounds. Then Kevin Hicks from nephrology. And then we're going to have Walter and Pam Polashensky, who I promised would never have to do this again, who will do a talk in tandem. And then two residents, Mamta Chamria and Dharmini Manogna, who will also talk to us about something that I think you'll find extremely interesting. So, Alok, I think the podium is yours.
No PowerPoint? Jeff? Oh, perfect. Thank you. Good morning. Thank you for this opportunity to address this audience in memory of and tribute to Dr. Gary Wall. This presentation is unlike any I've ever given. Without a defined subject matter, data, or outcomes to present, writing this provoked some angst. However, I found preparation for this talk to be an opportunity to rediscover why do we do what we do? What encounters and experiences elicit some of our strongest emotions? These questions can sometimes provoke thoughts and feelings we subconsciously sequester to survive one day at a time. It was an exercise to explore humanism in a field now dominated by metrics, sometimes without meaning. With my surgical background, I was trained to communicate objectivity. What is the relevant history, the pertinent findings? In residency, we were trained to communicate and weave the salient points into a short, four-sentence story. Terse, and often misunderstood by today's standards. Honestly, I was hoping to pull a bait and switch this morning. My instinct was to somehow twist this into talk about data. metabolic diseases, cost, value analysis. Even discussing the Krebs cycle sounded like a good idea at some point this morning. Anything with facts, figures, data. But why? Well, because that's easier to answer and to analyze than deliberating ideals and intangibles, many of which have no good answer. In healthcare, the actions and words of one individual can have everlasting consequences. Parallel examples in military, political science, history have shown that it is not uncommon for people charged with great responsibility to apply subjective filters to difficult problems. Actions and outcomes are often rationalized. This may not necessarily be a mechanism of ego protection, but rather a consequence of an outcome-driven environment. Favorable outcomes are not negotiable. The community, the patients expect it from us. We expect it from ourselves. We sometimes feel like, and occasionally labeled as heroes, saviors of the ill. Sometimes we feel like failures, unable to salvage those beyond the point of intervention. These highs and lows often resonate with us, weeks, months, sometimes our entire careers. After all, we are people, taking care of people. It has been echoed in our hallways that the relationships Dr. Gary Wald formed with his patients is that of legend. But he viewed certain technology to be a threat to the doctor-patient relationship, EMR. These interactions were being eroded by keyboards, prompts, and pop-ups. In a recent Forbes article, Dr. Robert Pearl, CEO and former CEO and surgeon of the Permanente Medical Group, eloquently discussed the ways that technology, the EMR specifically, was eroding and disrupting the patient-doctor relationship. He goes on to provide a concise yet insightful history, sordid history, of money, insurance companies, and the government. Interestingly, though, he also offered the most likely and most ironic solution: more and better technology. Today, we are using technology in ways beyond my imagination, technology which did not exist in my training. In the surgical world, Band-Aids easily hide our work thanks to robots. Heart failure patients are home with their families, making memories, with a mini heart driving output, not much bigger than a high school Sony Walkman. 3D brain mapping is sparing patients the sequelae of neurosurgery, and we are transforming breast cancer outcomes with intraoperative radiation therapy. But this technology goes far beyond the operating room. The use of technology here has saved countless lives with early detection of sepsis and prevented drug interactions in the era of polypharmacy. It has allowed our ICUs to take care of the sickest of the sick. However, with this technology, we are still people taking care of people. Atul Gawande depicts in his book titled Better the amazing and meaningful outcomes that can happen when we marry technology and techniques with data and outcomes. He articulates this by reviewing the history of the mortality rate of wounded American soldiers from the time of the Revolutionary War to the modern Middle Eastern conflicts. These systematic methods have led to treatment paradigm shifts, which have resulted in exponential improvement in the survival of our soldiers that can now come home to their family and kids. The future of technology in healthcare has unlimited potential. Artificial intelligence. I know, you're looking at me, I'm a surgeon. Artificial intelligence, or AI, is poised to further transform healthcare. The New York Times described how an MIT professor, now a breast cancer survivor, incorporated AI, artificial intelligence, to develop algorithms that have preliminarily doubled the identification of high-risk breast cancer patients. This has the potential to find tumors at a very early stage and thereby reduce the incidence of advanced stage diagnosis. This significantly improves survival with less morbidity and doing so in a cost-effective manner without there's concerns of over-testing. Undoubtedly, the future of healthcare will be intimately interwoven with data and technology. In fact, it is impossible to successfully run a healthcare system without data and technology. But it must be implemented in the appropriate context. Subtle clues, clinical judgment, experience should always be the commander, and technology our subservient partner. Patients often share their healthcare stories. These stories are based upon their experiences. We have all overheard these stories: backyard parties, the checkout line at Wegmans. Their experiences are rooted in interactions with people, not an app or a portal. Sometimes what we, as physicians, perceive to be a small, inconsequential interaction may in turn become the focal point of their stories. Perhaps one interpretation of humanity in healthcare is the ability to leverage our protocols, algorithms, and technology while still continuing to connect with patients. Humanism is our moral compass to accomplish this. The relationship that we develop with our patients goes far beyond the index ailment. It is also acknowledging and addressing the innumerable consequences of our patient's illness. The illness will affect their spouse, their family, their jobs, their business. There's never one patient on the OR table in front of me. Rather, we are operating on the entire community this one person touches. The responsibility is grave. Dr. Wall shared his insightful interpretation of what makes a good physician. It is memorialized on YouTube. He was willing to point out anything he saw as a barrier to good patient care and healthcare in general. We have all, in some way or form, been deputized to carry that charge. In the spirit of why we are gathered here today, we acknowledge that humanity in healthcare is bigger and larger than any one concept. At its very core, I interpret humanism in healthcare to be the relationships we develop with the patients we care for and all those affected by the illness. The legacy of Dr. Wall's impact on our community is revered and memorialized by this lecture series, and it is my honor to have shared my perspective with all of you this morning. After all, we are people taking care of people. Thank you. And Paul, still on time. Yep. Bye, Chase.
Dear friends, thank you for this invitation. It is an honor to speak to you this morning. I cannot help but start with a story that my sister, Michelle, loves because of the title on being a doctor. And I think Gary would have appreciated the story, and if you bear with me, I think I'll tie it in together with my bigger message. But I was coming over to my car after work one day late at night, and I hear this yell for help. Help, help, he's collapsed. And in the parking lot, someone had pulled into the ER, and beyond that 5-foot fence in the parking lot, there's a woman and a man is on the ground. And I'm coming to her, and it's right in front of my car. And I look around, and there's no one there. This is my moment. So I start running. I'm running towards my car, towards this fence, 5 foot tall, and I'm praying, Lord, help me get over this fence. And I hear, don't do it. So at the time, amazing enough, they were doing construction there, and there was a gap in the fence. Now, the woman and the man are right there. Yeah, they're right there. But there's the fence, and there's this gap. And so through the fence and I go. But it was one of these things, you got to use your imagination. It's one of those construction ramps with wheelbarrows. And so it's 5 feet from here to there, but it's 25 feet of ramp. And so I go through, and I'm still talking to him. Hang in there. I'm coming. And it's a true story. And so I get there, and the problem is I finally get to them, and I'm still a nephrologist. So, I swear, I think I asked what his potassium was. But the point of that is that, we all have days where we run 30 feet to move 3 feet. And at the end of the day, at least at that point in time, I was able to get to them, but many times we can't cross that barrier. Sometimes being a doctor is acknowledging that you can't be a patient. And when you acknowledge that, sometimes you need help. The reason I'm really here is because I work in a hemodialysis unit a lot. And I see this certain scene play out so oftentimes in the dialysis unit, I don't even stop to think about it. Every time I go into the dialysis unit, I see my patients there. I see your patients there. And for anyone who's not been inside a unit, it's an open floor plan. There's maybe 20 chairs, line of sight everywhere, so the nurses can see everything and react quickly if something happens. And so our patients are assigned specific times to come, specific days of the week, same time, same day of week. Same nursing staff, same patients around them, sitting in chairs just like you are beside one another. And this forges a link. We call it a dialysis unit, and that's what it is. It really is a de facto family that they join. And there's a side to it that we don't talk about enough. At least I don't talk about it enough. Maybe never. Because it's not really planned. It's just something that emerges from our human nature. And that is that our patients and our nurses and our techs and our teams, they see each other regularly. And they watch one another struggle. They watch one another struggle through the treatment itself, or through the procedures that are needed, or through the weather that assaults them as they try to get to and from the dialysis unit. The patients watch one another struggle through the diet, through the pills, through one another's successes and failures. We call this compliance. They watch that measured literally by the pound as they come into the dialysis unit and leave the dialysis unit. They watch battle scars from fistulas and catheters become so numerous and see the disfigurements become so severe they can't be concealed. And they know that not only is kidney disease progressive, but your time on dialysis is progressive as well. It's relentless. Some do escape through transplantation. Not enough. We need to do a better job. But for those who cannot, they stay. And they see their fellow patients start to move more slowly. They talk less, and they tell jokes a lot less. They see concern in nurses' eyes. They see who needs more attention from the staff, who gets nurses stand near patients more often. They watch as some patients get sick. Oftentimes, they get sick on the machine itself. Sometimes so sick they get sent to the hospital, and sometimes they never come back. Sometimes the very worst happens right in front of them. The patients see these empty chairs where once sat an acquaintance or even a friend. Always the same chair they're sitting in, with the same machine they have, getting the same treatment they have. What made the difference that day? And I like to imagine they see new patients and families come in and fill that empty spot. The rookies, the first dialysis. They're wide-eyed, they're scared, they don't know where to park or how to move around the unit. They don't know if they can ask for ice or a towel. They don't know what they're doing. And our patients, they see all this and they absorb it. And there's very little. There's nothing they can do medically to help. But they can do one thing, and it's the one thing that we can never do. And it's probably the most important thing that can ever be done and that we can ever ask them to do. And that is they can persevere. They can just show up. They can walk the walk. They can press on regardless. They can accept that their own disease is going to be on display for everyone to see, and they can still get into that arena 3 days a week, 52 weeks a year, for as long as they can. And over time, they can transform into quiet leaders. The great Dr. Viktor Frankl wrote this about suffering. He wrote, "What matters is to bear witness to the uniquely human potential at its best, which is to transform a personal tragedy into a triumph, to turn your predicament into a human achievement. When we are no longer able to change a situation like an incurable disease, we are challenged to change ourselves. And our patients, your patients, they do just that. Through pain and suffering and setbacks, and in spite of the outcome that is so often the result of chronic kidney disease, they do just that. So that was my goal, just to give you a snapshot of what we as nephrologists see from and ask from your patients, and in some cases, maybe your friends or family that come to our hemodialysis unit, and how much they mean to us and our team. Thank you very much.
Okay.
There should be a little manual with these.
Yeah. Is this on? Can you hear me? What do I do? How about now? How about now? Yeah. Okay. All right. So we're doing this together, but actually we're here to support each other because we're going to talk about some tough subjects personally. 3 years ago, I went in for my annual screening mammogram. As I had done in previous years, I waited for the results and was relieved to hear it was normal, and I was handed my appointment for the following year. As I was leaving the mammography unit, the nurse mentioned that because I had dense breast tissue, they were obligated by New York state law to offer me an ultrasound. If I wanted to pursue it, they could accommodate me immediately. After confirming that I had no meeting scheduled that morning, I decided to stay for the test. Partway through the ultrasound, my chatty technician became very quiet. After finishing the procedure, she said she was going to have the radiologist review it before having me get off the table. I knew I was in trouble. The radiologist came into the room and confirmed my suspicion that an abnormality had been found. My ultrasound showed a density in my right breast and 2 enlarged axillary lymph nodes. The radiologist biopsied both sites and told me that he'd call me with the results the next day. The following afternoon, I received the call that I was expecting. The biopsy confirmed breast cancer in both the breast and the lymph node. It was lobular breast cancer, which is less likely to form a palpable mass and is difficult to see on mammogram. The next several days were a whirlwind. I had an MRI to better visualize the cancer, a surgery consult to discuss my surgical options, and a plastic surgery consult to plan my reconstruction. The MRI was reassuring. It did not show any other abnormalities in my breasts or in any other lymph nodes. Given the failure of mammography to detect my cancer, I opted for a bilateral mastectomy, which was performed about 2 weeks after my initial diagnosis. The surgery was uneventful, and I was on my path to recovery when the pathology report came in. To our surprise, there were 5 foci of breast cancer in my right breast, 2 in the left breast, which was only removed prophylactically, and 27 of 29 lymph nodes were positive for breast cancer. It felt like a death sentence. Thankfully, my staging CT scans and bone scan did not show anything abnormal, except some small lesions in my pelvis, which appeared to be benign bone cysts. A follow-up PET scan was negative for metastatic disease, and I was labeled as stage 3C breast cancer. In order to reduce the risk of cancer recurrence or progression, I underwent 6 months of aggressive chemotherapy, followed by 7 weeks of radiation. At the time of my diagnosis, I was working in the role of Chief Medical Officer of the Eastern region. During my treatments, I continued my administrative responsibilities, which served as a good distraction from the difficulties of chemotherapy and radiation. After completing my treatments, I tried my best to return to normalcy, but struggled with the knowledge that my chance of progression to stage 4 was upwards of 40%. I started worrying that I wouldn't live long enough to enjoy retirement, that I would work full-time until my cancer progressed, and that I would be too ill to travel and visit my friends and family who are scattered across the globe. I actually came to this decision at Dr. Wall's funeral as I thought about his story, and I decided to scale back from working full-time to part-time, which necessitated me stepping down from my administrative role. I returned to clinical medicine in July of last year, working 75% as a hospitalist at Clifton Springs Hospital. In October of that same year, I took advantage of my increased time off to take a trip to Switzerland to visit my college roommate. We were hiking in the Black Forest on a beautiful autumn day when I noticed numbness down the back of my right leg into my foot. I diagnosed myself with sciatica and started doing stretching exercises and yoga. Despite these interventions, the numbness progressed and became bilateral. An MRI confirmed my worst fear. My sacrum was almost completely replaced by tumor, which was pushing on my bilateral S1 and S2 nerve roots. The MRI also showed multiple bone metastases in my pelvis and lumbar vertebrae. Those benign bone cysts we saw in the CT scan 2 years ago turned out not to be so benign. I underwent urgent radiation and was started on oral chemotherapy, as well as a more potent estrogen-blocking agent and infusions to improve my bone density. The new treatment schedule was difficult, but not unbearable, and I continued to care for patients, although my life now revolved around blood draws, injections, infusions, and scans. I decided to further reduce my hours to 50% to allow me to have time off during the week of treatment when I felt unwell, in addition to time off when I felt great, so I could enjoy my hobbies and visits with friends and family. As I was approaching July 2019, when this schedule change was going to happen, I noticed enlarged lymph nodes in my neck. I had one removed, and it confirmed that my cancer had spread. Follow-up CT scans also showed progression of my bone metastases, but thankfully no other organs were involved. This prompted a change in treatment to a different oral chemotherapy regimen with more significant side effects. The good news is I've had 2 rounds of scans since starting my new treatment regimen, and each time they've showed regression of the cancer in my lymph nodes and stability of my bone metastases. I'm learning to mitigate the side effects of this new chemotherapy, and I'm getting back to my active lifestyle. I've also learned some things along the way that I'd like to share with you. Number 1, I can't be a doctor and a patient on the same day. I used to schedule my infusions or CT scans to either early or late in the day to give myself time to round on patients. What I found is on days when I'm a cancer patient, I am not emotionally equipped to be the physician my patients deserve. I have grief, or I have difficulty empathizing on these days. My mind is distracted by anxiety, grief, anger, fear, and every other emotion that gets stirred up when dealing with a life-threatening disease. Now I take those days off. I allow myself to focus on me and lean on others for support. It's better for me, and it's certainly better for my patients. Number 2, to share or not to share. I recall in medical school being instructed to never share your personal struggles or medical history with patients because you risk shifting the focus from their needs to your own. Prior to my cancer diagnosis, I generally followed that advice. After my diagnosis, I intentionally waited to resume patient care until my hair had grown to a length that didn't make it obvious that I was a cancer patient. However, I work at Clifton Springs, which is a very small hospital, and many of the patients have chosen to be admitted there because it's where they receive their cancer care. It also happens to be the place where I receive my cancer care. So I was constantly running into patients that I had cared for in the hospital in the oncology waiting room, or they were next to me in my infusion chair. And in response to the awkward stares that they were giving me, I started sharing my diagnosis with these patients, and I was amazed at the positive response and feedback I received. Many of my patients and their family members told me they feel more comfortable being in the hospital under the care of a physician who truly understands what they're going through. So now I frequently share my cancer diagnosis with my patients who also have cancer. It's allowed me to establish a rapport that is unique, powerful, and I'm told therapeutic for both the patients and their family members. Obviously, it's not the leading part of my first encounter, but when my gut tells me that it might help, I generally share. Number 3, live in the moment. When I was first diagnosed with stage 4 cancer, I was devastated. That first night, I was wide awake at 4 a.m. in complete panic mode. All I could think about was my death and dying, leaving behind my family, letting go of my ultimate goal of growing old with my best friend and life partner. In an effort to try to combat my anxiety, I put some headphones on and downloaded a meditation app that was designed for cancer patients. The focus of this particular meditation exercise was to live in the moment, stay in the present. This idea seems cliche and obvious, but at that time, it was very powerful. The gist was, you woke up breathing, you're alive today, focus on the present. And that's literally become the mantra I start every day with. I woke up breathing, I feel good, I'm going to have a great day. And whenever my mind starts to move towards that unknowable, scary future, I do my best to bring it back to focus on today. Number 4, and there's only 5, so we're almost done. Number 4, find a support group. I think it's second nature to turn towards the people who love us most when we need support. And of course, I still do that. But every time I shared my worst fears, my current struggles with my family or my closest friends, I would see the look on their face, and it would break my heart. It began to feel cruel. No one can take this disease from me, so why share these feelings when all it does is cause pain to the people I love? But keeping it bottled up didn't help me, nor was it realistic. Fortunately, I stumbled upon some great support groups through the Breast Cancer Coalition, and it has actually been incredibly helpful. These are women who feel the same way I feel and are dealing with the same struggles. When we share with each other, and believe me, we share, we get back helpful advice, or at least camaraderie, without feeling as if we're inflicting pain. And finally, I've learned how to live. Obviously, cancer is ever present in my life. I take chemotherapy pills twice a day and have devised creative yet very time-consuming strategies to mitigate the side effects. I have regular appointments for acupuncture and massage therapy to help with cancer and treatment-related symptoms. I plan my vacations around oncology visits, CT scans, blood draws, and chemotherapy side effects. The reality is I will always have cancer, and I will always have cancer treatments. My hope is to live with cancer well into old age. And while I'm at it, I'm doing my best to focus more on the living and less on the cancer. I continue to travel and take vacations. In the last 2 months, I've ridden my bike from Rochester to Albany. I've summited 3 high peaks in the Adirondacks and have competed in multiple beach volleyball matches and tournaments. There's a saying from Confucius that states, "We have 2 lives, and the second begins when we realize we only have one." I am living that second life and making the most of it. I wish you all the same.
I don't want there to be any misconceptions. I'm not up here to support Pam. She's up here to support me. And I also would like you all to know that you're here for my first group therapy session. And I have my pink handkerchief if I need it. All right. So the first thing that I want to share about my story is that I don't believe I have any new discoveries. The things I'm saying to you today are things that our patients have gone through and their loved ones have gone through for as long as there have been patients. My discoveries are mine only. I guess we all get to make them at some point, and I'm going to share how I've lived them and what they've meant to me. I'll start off by sharing a secret. Disease has always been something that happened to my patients. I help people get better. I don't need help. I suspect there's a little of that in all of us who invested so much of our time learning how to battle disease, a belief that somehow understanding and treating disease gives us and our loved ones immunity to disease. Perhaps that's why we're such bad patients. It's never been explicitly stated. I never told anybody I believed this. If someone had asked me, "Do you think your wife could get sick?" I would have said, "It's possible. We all get sick." But at the end of the day, illness was still something that happened to my patients. I suppose that's why I've really struggled talking about Pam's illness. Talking about it, owning it, is owning a weakness that I shouldn't have. Pam and I are doctors, damn it. We're not patients. Some part of me, perhaps a very important part of me, is really threatened by Pam's illness. Some part of me worries that I will give up a part of my identity if I become a patient's family member, or heaven forbid, if I become a patient myself. When I hear myself read that, I know that sounds ridiculous, but there it is. Admitting that my wife, and by extension myself, is subject to disease, to patientness, is painful and frightening. It whittles away at carefully constructed barriers that I've put in place to distract me from remembering I'm just like everybody else. I live, and I work, and I play, and one day I will get sick, and one day I will die. I've thought about dying a lot for the past few years. As an internist, I've had the privilege, time and again, of telling people, don't worry. That pain is nothing. That pain is not a heart attack. That pain is not cancer. That pain is not a bleed in your brain. In our line of work, most worries are just worries. We get to dispel the worries. But I found that I have difficulty doing that now. Every time Pam has a pain now, I worry. Or I worry that I don't worry enough. Many of our worries have been corroborated. There is cancer, and the cancer has caused symptoms, and these have been symptoms that I would have dismissed 3 years ago. Back pain, lumps and bumps. And when your wife continues to play competitive volleyball 3 to 4 times a week, downhill ski and climb mountains despite her widespread bony metastases, believe me, there are worries. Then what about my worries? I find that I cannot so blithely assert to myself that it's nothing anymore when I feel things. So I worry about things I've never worried about, and I find myself wondering, how much time is left? For the two of us? For me? I'm way too young to think like this. But some days I can't help it. It's staring me in the face. Maybe not every day, but many days. Too many days. Our plan from our earliest days of being physicians was that when I turned 50, a couple of years ago, I was going to step away from hospital leadership and begin to work part-time. I've been a leader in my group and in the hospital for going on 20 years. Many say that's going on 19 years too long. I planned that I would finally have time to do what I've dreamed of doing since I was in college. I was going to be a writer. I was going to write fiction. I'm still going to be a writer. Pam would continue to work, trooper that she is, perhaps growing into a leadership role as I vacated mine. We were right on schedule. Pam was growing as a leader in the Eastern region. I was beginning to dream about that part-time job. And then, boom, cancer changed it all. One day, as we discussed the future and the toll that treatment was taking on her nerves and on her energy, Pam told me, I don't know if I'm going to get a retirement. I need to work part-time now. She needed to get a retirement now. Time to rest when treatment was exhausting, time to be free to visit family and friends, time not to think about other people's illnesses. And I'll admit that's been hard for me. Should I go part-time and have extra time to spend with Pam and family? I worry that if I wait, I'll retire alone. That's not what I planned. Can we afford to live if we both go part-time? We had 3 kids who were in college at the same time. What if Pam's treatment becomes more expensive? I don't know. And some days I look at the things I've accomplished at work and I wonder, am I ready to give it up? Some days, absolutely. But for good, I don't know. I'm torn. And so I do nothing. And I admit it doesn't feel as good as it once did. Many of you who know me will know that I enjoy reading the medical literature. I've built a teaching niche for myself, helping residents to understand how to look for bias in research and how to apply results of studies to their patient care. I have been absolutely surprised, almost stunned, to discover that knowledge about Pam's cancer brings me no comfort, and it offers no protections. In 3 years, I haven't read a single study on breast cancer. I don't want to know facts. I have no reserve to think objectively about results or how to apply them to a loved one. I give credit to Pam because she does, and then I give thanks to her because she spares me. I just want to believe that things will be okay. Staying the same is acceptable. I don't want to know survival rates. I'm thankful for all the physicians and nurses who have cared for Pam and who have remained so positive and so reassuring. That means more than words can say. And finally, I would be remiss if I didn't mention all of you. All of my partners and colleagues and nurses and therapists and social workers and Sister Margaret and everyone else. Not a day goes by, Often not an hour goes by without someone checking in on me to know how Pam is doing. It's bittersweet. I hate it that there is something to check in on, and I hate being reminded. I'd rather that Pam was healthy and boring. But since I don't get to choose these things, I must express my gratitude for all the love and support that the people I've worked beside for so long care enough to ask. Thank you for caring, and please don't be offended when my answers are short.
Can you hear me? Good morning, everyone. We're going to do something a little different today. It took us a little while to think about this, and it somehow came together, and we hope you appreciate it. So I've always been inclined towards the creative arts, especially music and painting. Belonging to an Indian family, born and raised in urban India by my highly educated parents, one of whom happens to be a practicing anesthesiologist, pursuing fine arts as a degree was just never an option. With a childhood that was focused on acing entrance tests, I automatically chose to pursue my higher education in the scientific field. Creative pursuits were shoved into a compact corner in the back of my mind. Because the Indian school system is probably one of the most competitive in the world. As my mom always said, anything less than 100 in math is probably equivalent to failing. And I think a lot of the residents here who've been raised in India by parents such as mine would totally agree with me. Either you were the best or you were nothing. And there was very little room for artistic or abstract thinking. When I joined medical school, however, I began to notice a change. The first time I picked up the Netter's Atlas, I was dumbstruck. Those beautiful illustrations, the complexity of the human anatomy, the fact that it did not fit into some pre-derived scientific formula appealed to me, as did the creative genius of Dr. Frank Netter himself. I started to see this pattern of art being hidden in plain sight in many aspects in the day-to-day practice of medicine. The beauty in every cell and the microscopic anatomy of organs is art. That a cell in one part of the human body should be so different from a cell in another is mind-boggling to me. That genes are processed to express so many different phenotypes, that even when there is organization of DNA in the form of chromosomes, there is still room for so many different permutations and combinations to produce over 7 billion unique entities on this planet. There's art at a macroscopic, microscopic, and molecular level in this field. And this has always enamored me. And as Dharmini will now tell us, just as there is a representation of art in medicine, so also is there a wonderful representation of music in it.
When someone asked me why I wanted to talk about this today, I was really able to trace the inception of my interest in music and medicine to one incident in my life. When I was about 14 years old, my father underwent a second, quite complicated orthopedic surgery with a prolonged rehabilitation course. A workaholic in every sense of the word, it troubled him tremendously to take time off and stay at home for 3 months while diligently working with physical therapy. At that time, I was preparing for a certification course in Indian classical dance, for which a certain degree of knowledge in Indian classical music was a prerequisite. I would often practice at home after school, and on one such day, I didn't realize that I was within his earshot. He made a unique request that evening. He asked, "Would you be okay to sit beside me while you're practicing?" And so I did. For starters, you never said no to your dad back home. Everybody's familiar with the somebody's gonna get hurt real bad concept. But I did it. I don't think I was ever particularly good at it, but I sat beside him and sang for an hour or two every day for a couple months. It was several years later that he told me it was the 1 hour of his day that he would look forward to the most during that testing time. The utilization of music as a therapeutic tool is not new. In fact, it's probably as old as medicine itself. In addition to unifying humanity on cultural grounds, the benefits of music on mental and physical well-being have been talked about as early as the 17th century. However, this is the era of evidence-based medicine. And in fact, research has confirmed the efficacy of medicine as a treatment modality. For instance, premature infants who were exposed to music were found to have shorter hospitalizations and quicker recovery. On the other end of the age spectrum, geriatric patients with neurodegenerative conditions have been proven to experience slowing in the progression of their respective diseases. Music therapy has also been well studied in cancer patients. There is evidence of significant reduction in anxiety and depression, along with improved quality of life, having been confirmed by randomized trials. So, it has been established that it's effective, but is there something beyond that?
Fast forward to the present. Can you hear me? Sorry. My time as a medical resident. My formative year as an intern that just passed by has shaped me in many different ways. Art was beginning to show in different places now, not in the algorithms and illustrations of my textbooks, but in living, breathing human beings, each with their own physiologies and histories. This was a new art form that I needed to master, the art of the medical practice. In every patient interaction, there was a learning point, and each learning point was rooted, it had a foundation in scientific literature, but an artistic side, in the sense that no two physicians practiced in the exact same way. The time I had two leukemic patients who were comparable in every aspect, except that one took his diagnosis rather badly and ended up experiencing a much more complicated course, showed me that even in showed me that emotions play such a huge role in the human experience and in outcomes of patients. The time my opioid-addicted patient allowed only me to femstick him for a blood sample showed me how important trust is in this patient-physician relationship. The time the family of a young gentleman with WPW syndrome who came in post-cardiac arrest told me that they felt supported with me in the loop showed me that even in the face of tragedy, humanity somehow sustains itself. The artist focuses their complete attention on the painting and the paintbrush, just as the physician focuses their complete attention on the patient. There is an art to the delivery of the diagnosis, just as there is science to the diagnosis itself. And how does music tie into this patient communication front?
A little over a month ago, I had the opportunity to rotate on a bone marrow transplant service. Thinking back, one experience truly stands out. One of the post-transplant patients had a particularly complicated course, with her hospitalization approaching over a month. The first time I met her during morning rounds, I noticed something unique about her room. Melodious jazz music in the background went against your typical patient room setting. Walking past her room, I'd noticed that sometimes the music was louder than others. It was later that one of her nurses told me that the patient would regulate her sonority based on the pain levels. A hopeful therapeutic plea, it had suddenly transformed into a means of communication. If the music got louder, The nurse would anticipate that the patient was likely in pain and would go check with her if she needed her as-needed pain medication. Yes, it had become a nonverbal cue indeed. On the day she was leaving, I went to give her the news about her discharge. Strangely, I heard no music. I popped my head in, almost expecting her absence, because this was quite unusual. However, in there she was, casually flipping the pages of a novel. I thought I was in the wrong room for a second. What with no music here, I commented. She replied, well, for the first time in nearly 4 weeks, I'm pain-free. I thought I should use my medicine judiciously, and thus I decided to turn the music off. That right there drove the point home for sure. Delving into deeper thought here, there's music in everyone and in everything. What I find quite amazing is that the human body itself is an amalgamation of several rhythms. And for most of our lives as physicians, our work revolves around restoring one of those rhythms to perfect synchrony. The regular heartbeat, the beautiful, nice blood flow, rhythmic peristalsis, or symmetrical expansile lung movements. The rhythm is the essence.
In fact, music and art in medicine are omnipresent and endless.
A neonate's cry that every obstetrician yearns for.
Innocent pictures on the walls of pediatric offices.
The alarm on the telemetry monitor that draws every provider's attention.
The curves and lines on that monitor, each with their own significance.
The beep preceding an overhead page that scares every resident.
The well-illustrated ACLS flowcharts that we carry in anticipation of that moment.
Lament of grief at life's end.
The art of palliative medicine to offer the best support. From the beginning to the very end, there is so much more to practicing medicine than medicine itself.
We explore the length and breadth of the human experience. We witness human joy and human suffering up close and in their most unadulterated forms. Isn't this what art and music are also about?
Thank you so much.
Give a rousing applause for the 6 people that poured their hearts out today. I think we all understand how important this is as providers or not, how this enriches our lives. And my expectation is that today's grand rounds change you a little bit. It takes great courage for the people that were in front of you to admit their vulnerabilities and recognize how strong and important this is. And that's why I stood up before you. I would also like to point out that last year I had asked the 4 people to give presentations. This year we had to turn people away, and I'm hopeful that next year we have even more of you trying to submit to contribute. And Gary knew that too. In terms of one final story, he was very, very sick, as you guys know, just before he spoke. In fact, thanks to Dr. Casey, he made it out of the hospital the night before. But I had phoned him that evening and said, you know, Gary, what are we going to do if you're still up on the floor? And he said, you're going to come upstairs, and I'm going to sit in a wheelchair, and you'll wheel me down here. So that kind of strength you saw today as well. We do have just a few minutes. I'd like to open this up to the audience for comments or questions to any of our speakers. Nadine. Yes.
So did you help that person?
Turns out he was fine, and I only had a small amount of part.
Okay. Any other comments or questions? All right, well, thank you all very much, and thank you for the Wall family, too, for joining us.